Bismillahirrahmanirrahim. Remodeling of bone is discussed in this video. Bone tissue is in a constant state of turnover, and this is called bone remodeling. This is a dynamic process and involves osteoblast, the bone forming cells, which deposit new bone matrix. These cells are primarily located on the outer bone surface and inside bone cavities. Even in healthy adults, about 4% of all bone surfaces show osteoblastic activity at any given time. This means new bone is always being formed, ensuring repair, reshaping, and maintaining bone strength and mineral homeostasis. In tandem, the bone is also being resorbed by osteoclasts, the bone breaking cells. They ensure balance between the formation and removal. So this allows bone to adopt the mechanical stress, heal microfracture, and adjust calcium and phosphate levels in the blood. This is a histological diagram of bone tissue showing the dynamic process of bone remodeling. It highlights the two main cell types that are involved in bone turnover, the osteoblast and osteoclast. There is also this fibrous periosteum. This is the top layer or outermost layer. It is a dense layer of vascular connective tissue that covers bone except at the surface of the joint. It provides structural support and houses osteogenic cells. The osteoblast are bone forming cells located along the edges of the bone, and they secrete the bone matrix that is osteoid and responsible for bone deposition and mineralization. The osteoclasts are large cells, multinucleated cells. They resorb or break down bone tissue and they are located in small pits that are called Hauschep's lacunae, and they secrete acids and enzymes to dissolve bone matrix and release calcium and phosphate into the blood. There is a vein that is indicating vascularization, which is crucial for the transport of the nutrients, removing waste and facilitating communication between bone cells and systemic circulation. The dense area, this dense area that is shown in red, represent the mineralized bone matrix, providing strength and structural integrity. So there is a bone remodeling, the continuous cycling of bone resorption by osteoclast and bone formation by the osteoblast. This process of remodeling maintains the strength of the bone, regulates calcium and phosphate level, and adapts bone architecture based on mechanical stress. This picture is describing the process. The two main cells of the bone remodeling are osteoclasts and osteoblasts. The osteoblasts are responsible for the deposition of the bone for the because they have got the ability to secrete various compounds, chemicals, and cytokines that are responsible for the deposition of the bone, while there are osteoclast large cells, multinucleated cells that are present in the Hauschep lacunae, and they are responsible for the resorption of the bone. So osteoclasts are multinucleated cells that are responsible for bone resorption. They are large cells, have got phagocytic activity. They have got 6 to 12 or up to 20 nuclei, and they are derived from monocytes, and usually They are active on less than 1% of the bone surface of an adult. Multinucleated cells, large, that have got derivation from the monocytes and responsible for the resorption of the bone, and they are regulated by parathyroid hormone, and this bone absorption occur immediately adjacent to the osteoclast. The osteoclast anchor tightly to the bone surface, and they then make a tight seal around the area where they are attached, and then they send in or extend villus-like projection forming a ruffled border. So these projections, they increase the surface area that is in contact with the bone. So then they secrete two major types of substances, proteolytic enzymes from the lysosomes. These digest the protein or collagen fiber and other organic components of the bone matrix, and then they also secrete acid, the citric acid and lactic acid, that are from the mitochondria and vesicles, secretory vesicles. They dissolve the inorganic mineral salts, mainly hydroxyapatite. So then the process of phagocytosis occur, and these osteoclasts engulf small bone particles and crystal via this process of the phagocytosis. They are digested intracellularly and broken down into a small product like calcium and phosphate, and then are released into the bloodstream. So osteoblasts have got rank ligand or osteoprotein ligand and macrophage colony stimulating factor on their surface, and these osteoblasts through these two are responsible for the activation or maturation of the osteoclast. So parathyroid hormone binds to the receptor on the osteoblast, not on the osteoclast. And osteoblasts respond by increased rank ligand synthesis that promotes osteoclast maturation. Decreased osteoprotein synthesis will lead to less inhibition of osteoclastogenesis. Rank ligand binds to rank on pre-osteoclast, and these are present. Rank is present on immature osteoclast, and due to this rank ligand or rank interaction, the immature osteoclasts are matured into active osteoclast, and active osteoclasts then develop ruffled border to increase the surface area. Then there is enzymic and acid release in that particular milieu, and then the resorption of the bone occur. Osteoprotein act as a natural inhibitor, binding rank ligand and blocking its interaction with the rank. So osteoprotein inhibits the resorption of the bone, and its deficiency will result in soft bone formation. Parathyroid hormone blocks this osteoprotein and increase the rank ligand activity, decrease the osteoprotein, and so it will result in increased osteoclast formation, while vitamin D is also responsible for same effect. It increases rank ligand, decreases osteoprotein, and is responsible for bone resorption. Glucocorticoids, they are responsible for increase rank ligand, decrease osteoprotein, and increase bone loss risk, while estrogen is responsible for increased osteoprotection and decreased osteoclastic activity. So, drug mimicking the osteoprotein such as denosumab, they block the rank ligand that is useful in postmenopausal osteoporosis and bone metastasis, and also it is helpful in cancer related bone loss. So this picture is summarizing this concept. The parathyroid hormone binds with the osteoblast, and through this binding it sends its signal. So it activates the rank and rank ligand interaction and activates the osteoclast. The osteoclasts are matured, and due to this maturation, after this maturation, they exert their effect. That means they are responsible for the resorption of the bone. Osteoprotein is a decoy receptor, and this molecule it inhibits osteoprotein. It inhibits the bone resorption, and osteoclast activity is also influenced by vitamin D, estrogen, and glucocorticoid, as we have seen earlier. So we have just discussed the paracrine molecular mechanism that regulate osteoclast formation and their activation. Just to re-emphasize the mechanism, these transmembrane receptor of rank or receptor activator of nuclear factor kappa B, they are present on the osteoblast, and the decoy receptor osteoprotein, it blocks the activity of rank and rank ligand interaction. So these rank ligand that are present on the osteoblast, in the presence of osteoprotein or this osteoprotein that act as decoy receptor, they do not bind with this osteoclast precursor cell. But when the osteoprotein is removed, they then interact with the rank receptor, and with the rank receptor activation, they are responsible for activation of the nuclear factor kappa B. That is then responsible for the activation of these or maturation of these osteoclasts. So this is one mechanism. Then there is another mechanism of this activation is through the macrophage colony stimulating factor. These macrophage colony stimulating factor that are produced by the osteoclast, and these MCSF receptors, they are then responsible for the activation of this uh, tyrosine kinase activity that is also crucial for the generation of osteoclast. Other notable pathway is the Wnt beta-catenin pathway or wingless interaction pathway. This protein produced by the osteoprogenitor cells that are bind to LRP5 and LRP6 receptor on the osteoblast. These LRPs are LDL receptor related proteins. Then these trigger the activation of beta-catenin and production of osteoprotein. Sclerostin is another protein that is produced by osteocytes, and it inhibits the Wnt beta-catenin signaling and promote the growth of the bone. If there is any mutation in these molecules, osteoprotein, rank ligand, LRP4 and LRP4A5, and sclerostin gene, it may result in congenital bone disorders. This image is a cellular and molecular illustration of bone resorption regulated by parathyroid hormone, vitamin D. and key proteins such as rank and macrophage colony stimulating factor and osteoprotectin. It highlights the communication between osteoblast and osteoclast in bone metabolism. This crosstalk is very essential because the parathyroid hormone and other factors, they send the signal through the osteoblast to work to start the work of the osteoclast. The osteoblasts are bone-forming cells that are lining the bone surfaces. When stimulated by parathyroid hormone and vitamin D, they release rank ligand, the receptor activator of nuclear factor kappa B ligand, and also secrete macrophage colony stimulating factor and suppress the production of the osteoprotectin and pro-osteoclast transformation to the osteoclast then occur. The rank ligand, how? The rank ligand, this binds to the rank receptor on the pro-osteoclast. Rank ligand binds with the rank receptors on the pro-osteoclast, and this macrophage colony stimulating factor, as we have seen earlier, also stimulate their maturation. These signals convert the pro-osteoclast or immature osteoclast into mature osteoclast. And osteoprotectin, it acts as a decoy receptor for rank ligand. It prevents rank ligand from activating rank, thereby inhibiting the formation of osteoclast. The mature osteoclast develop a ruffled border, this highly convoluted or highly uh, projected, this ruffled border, this is formed at the bone surface, and it secretes acid and also lysosomal enzyme. Acid dissolve the mineralized bone while the lysosomal enzymes, they digest the organic matrix. This creates the area of bone resorption. There is a tight seal to stop the spillage of these enzymes, and uh, within this tight seal, this area of the bone resorption is developed. Then the osteocytes are the former osteoblasts. These osteoblasts, they are embedded in the bone and form a cellular network inside the bone matrix. They are the osteocytes. They help monitor and maintain the bone health and structure. So this system maintain the calcium and phosphate balance and remodels bone based on metabolic need or mechanical stress. So parathyroid hormone and vitamin D, they increase the bone resorption, and osteoprotectin, it decreases bone resorption by blocking the rank ligand. So here the bone remodeling it occurs in equilibrium. In adults, the deposition of the bone is equal to the breakdown of the bone or resorption of the bone. So the stable bone mass is achieved or maintained. In the resorption phase, that is led by osteoclast, which are bone resorbing cell, they gather in a small concentration uh, or a small group, and these cells digest bone for about 3 weeks, creating a tunnel. This tunnel is about zero point 0.2 to 1 millimeter in diameter and many millimeter long. And then the these osteoclasts, after they form the tunnel, they disappear, and osteoblasts, that are the bone forming cells, they appear and they invade the tunnel. New bone is deposited in the concentric layer that are called lamellae. This continues for months until the tunnel is filled, leaving a central canal for blood vessel that is called the uh, Haversian canal. So this is called the Haversian canal. So a complete new structure formed by this process is called osteon. An osteon is the fundamental structure unit of the compact bone, critical for maintaining bone strength and health. So this diagram of bone deposition and absorption illustrates the hormonal regulation and cellular mechanism that are involved in maintaining bone health and structures through a balance between the bone formation and breakdown. So at the center is the concept of equilibrium between the bone deposition, that is formation of the bone by osteoblast, and bone resorption, that is the resorption or breakdown of the bone by the osteoclast. The parathyroid hormone and vitamin D, they promote the resorption of the bone. Parathyroid hormone and vitamin D, they promote the bone resorption, and stimulation of the rank ligand production will inhibit the osteoprotein production. Estrogen, it will increase the bone deposition and increase the osteoprotein level that breaks the breakdown of the bone. Glucocorticoids, they promote the bone resorption, and they also decrease the suppression of the osteoprotein, so more active osteoclasts are produced. So osteoblasts, that are the bone forming cells, they produced rank ligand, and this stimulates osteoclast production. Osteoprotein binds with the rank ligand, preventing it from activating osteoclast. And osteoclasts are the bone resorption cells. They are activated via rank ligand, rank interaction. Rank is on their surface, so rank ligand and rank when interacted. So there is maturation of these osteoclasts. So rank ligand binds with the rank, and this will lead to osteoclast activation. These activation of the osteoclast will result in the bone resorption. Osteoprotein block the rank ligand and rank activity, so it inhibits the resorption of the bone. So osteon is the fundamental unit of the compact bone. It is the it has got the lamellae, that are the concentric layers of the bone tissue, and a central channel, that is the Haversian canal, and that contain the blood vessels. So here it is simplified that if this picture is simplifying the dynamic interplay between the hormones, signaling proteins, and cells that ensure healthy bone maintenance throughout the life. So this mechanism of bone remodeling is very important because the bone adjusts its strength in proportion to the degree of the bone stress. So the load-bearing bone is strengthened in response to increased stress from this increased stress may be caused by weightlifting or physical activity. This adaptation leads to bone thickening and increase in structural durability where it is needed. Then a shape uh, of the bone can be arranged for the proper support of mechanical forces. The bone can change its shape through selective resorption and deposition. This ensures the bone align properly with mechanical forces, improving posture and load distribution. This is key in healing and growth. Then there is replacement of the brittle bone matrix. Over time, the organic matrix in bone ages and becomes brittle. The remodeling replaces the old matrix with new one to maintain flexibility and toughness. And children have rapid remodeling, so their bones are strong and flexible. In contrast, elderly people have slower remodeling, contributing to brittle bone and fracture risk. In summary, the bone remodeling enhances strength, maintains shape and function, and replaces aged and weak bones to prevent brittleness. The rate and shape of the bone deposition are strongly influenced by mechanical stress, meaning the bone physically adapts to the forces applied to it. The bone deposition is proportional to its load. So the bone is strengthened and thickened in response to the compressional load or physical stress. For example, in athletes, often they developed heavier, denser bone than the non-athlete. If a limb is immobilized in a plaster of Paris cast, the lack of stress leads to rapid thinning of the bone and decalcification may occur around 30%. Meanwhile, the active limb retains normal bone density. The bone stress also determines or influence the shape of the bone. When bone heals at angles such as after a fracture, the compression side where on the compression side there will be more osteoblastic activity, so there will be increased bone deposition, and non-compression side or tension side will have more bone resorption. Over time, especially in children, this natural process can gradually strengthen misaligned bone due to rapid remodeling. So the stress guides the strength. The more you use a bone, especially under pressure, the more it reinforces itself. Osteoblasts or bone forming cell in the periosteum and bone interior are maximally activated in the case of the fracture. Osteoprogenitor cells, the bone stem cells in the membrane, rapidly differentiate into new osteoblasts, and this create a large population of the osteoblasts that are ready to build a bone. So, a large bulge of osteoblastic tissue is formed between the two broken ends, and these osteoblasts lay down new organic matrix that is termed as osteoids. Soon after, calcium salts are deposited, forming a hard callus and stabilizing the fracture. Then Orthopedic surgeons often use external fixative devices such as rods, plates, screws that allow the controlled movement. This controlled stress on the healing bone stimulates osteoblast even more, that result in faster bone repair, a stronger callus formation, and shortened recovery time. So the bone fracture triggers an intense osteoblastic response, forming a callus that bridges the break, and controlled physical stress enhances this process by accelerating the osteoblastic activity and regeneration of the bone. Thank you for watching this video. If you have any query, please write in the comment box.